Hello, my name is Rocky Hill, and I'm Director of Hill Alcohol and Drug Treatment in Temecula, California, and Three Hills Ranch Residential Recovery. And we're going to talk today a little bit about what is addiction, but most of all about a revolutionary concept, and probably the biggest thing I've seen in terms of a change in addiction treatment in the last probably 25 years. And it relates to opiate addiction, and the medication is Suboxone. And so we're going to talk about that and go into the details of the benefits and the liabilities and the use and some of those kinds of things, so that each of you will get a better understanding of hopefully what addiction is, but especially as it relates to opiate addiction, which is right now we're seeing a huge upsurge of the use of drugs like prescription drugs like Vicodin, Norco, OxyContin, that then very often morph into eventually the use of heroin. And this is specifically hitting our young people in the ages between 18 and 25. And as a clinician, this is worrisome for us. But again, I don't like to use the miracle word when we talk about addiction, because we've had in the past supposed miracles that were going to be the cure, and in fact there was no cure. Addiction is a disease that is prone to relapse, and that continues today. But we have a new tool, and more we're seeing that new tools are coming from science. And this is just a new way of dealing with opiate addiction and enhancing what we do in the treatment process. And so we want to talk about it today and go into detail and perhaps demystify and clarify some of the realities of opiate addiction, what happens to the brain, and Suboxone. I've got about 28 years in this field now in addiction treatment. Prior to that, I was a juvenile parole officer for the state of Oklahoma. I had my own problems with alcohol and drug addiction. I spent 14 years using all types of drugs: alcohol, methamphetamine, cocaine, opiates, barbiturates, lots of different types of street drugs and prescription medications. And finally, actually today, December 3rd, 1980, I went through treatment and fortunately have been able to remain clean and sober since then. And so there is hope for recovery, and we're going to talk a little bit about the specifics of addiction, recovery, and how it applies to the drug opiates. Let's look first at what addiction is. We need to at least clarify that very briefly. We've got some other videos that deal with addiction and defining it in detail, but we need to at least touch on it. And I want to define what is addiction, because very often we hear people talk about quantities and frequencies and those kinds of things and whether you can stop or not. And it has nothing to do with quantity, frequency, whether you can stop using the substance. That's irrelevant to the definition or diagnosis of addiction. Addiction is defined very, very simply. And when we talk about addiction, we're not just talking about substance addiction, alcohol, methamphetamine, cocaine, those things. We're also talking about behaviors like gambling, food, exercise. There are other types of addictive behaviors. But when we truly see addiction, we see some very common kinds of things. And obviously with the substance addiction, there's some type of use of the substance. Again, it doesn't matter how much, doesn't matter how often, doesn't matter what time of day, whether it's how the substance is induced into the individual system. The point is that the substance is used and there's some kind of a problem in life functioning. A problem that creates some degree of pain for the individual. That in and of itself is not enough to define addiction. So if I get drunk today and I go out and I have an accident and I kill somebody, that isn't addiction. Addiction is the insanity of the return to the use of the substance or the behavior despite negative consequences. That's addiction. And it doesn't mean that every time that I use, I have a problem. It just means that there is enough of a correlation between the use and the problem that I can see there's some relationship. And it doesn't mean that every time I have a problem that creates pain, related to the use that I immediately go back. It may be once every 6 months or so. But there's enough that we can see, in fact, there are problems related to the use, and despite that, there's a return to the use, and this pattern becomes more and more concrete in the individual's life and easy to see for people outside the system, outside that individual. When we look at, and of course the use of the substances, we're talking about the vast realm of psychoactive chemicals, methamphetamine, cocaine, all the prescription drugs, Xanax, Valium, Librium, Ativan, the opiates, the Vicodin, Oxycontin, Norco, Dilaudid, street drugs, heroin, those kinds of things. Those are the kinds of drugs that we're talking about. But we don't see people coming in addicted to LSD. We don't see people coming in addicted to mescaline or psilocybin or peyote. They're drugs that ultimately do one thing. They change the way we feel. They take us from point A to point B. Some degree of discomfort to a greater degree of comfort. That's the purpose. That's the sole reason that we use the substance. So then when we look at these problems, we look at, well, what is it that is involved in the problems? Because obviously, having a painful situation or circumstance, it's not normal to go back to that again. It's not normal to go back to the source of that again. If I eat green beans and I break out in hives, I don't eat green beans again. I say, no, thank you, I'm allergic to that. I don't do that. And so this is an abnormal response to pain to continue to use. And obviously there's a reason for it, the reason being it changes the way we feel. And that's pure and simple. There's a powerful element called denial. And when we look at denial, denial says things like, I don't drink that much, I don't use that much. If I use as much as Joe did, then I'd quit. Says those problems aren't really that big. Most of all, it says things like, there's no relationship between my use and the problem. The reason I drink this much, you'd have to too if you had the job you have, if you had the wife I have, whatever the manifestation the denial takes. But it's either minimization, justification, rationalization, intellectualization, some way of defending the ability to go from point A to point B. Because I don't know any other way to get from this discomfort, this boredom, lonely, emptiness, inadequacy, whatever these feelings are, that the substance changes for me. Don't know how else to do it. So I'm going to deny that to the nth degree because I have no other options. And so treatment and recovery are about introducing people and breaking that denial by giving them ways to get from point A to point B without using substances. And with opiate addiction, we have known for years that the recovery rate has been probably 5 to 10%. And that's probably not something you would hear from most people in a treatment program, but it's the truth. You know, we would see people go through the initial stages of opiate addiction and get through the withdrawal and then be unable to sustain their recovery. Whereas the person who was addicted to alcohol, methamphetamine, cocaine, they continued their recovery and were able to do fine. But with opiate addiction, we found that they just simply weren't able to do that. So when we look at lost my thing here, it's supposed to be over here. When we look at the different types of problems that we have, there are some pretty predictable kinds of things that happen behind the use of psychoactive substances that we become addicted to. So the problems are typically legal, health, school, work, financial, and always, 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 may not be these, but it's always family. Substance abuse, first and foremost, causes problems in the family system. And so we look at these kinds of issues and how ultimately the substance use creates these problems and the pain related to that, and despite that we continue to go back to the use of the substance again. And so ultimately when we look at, okay, well, what is it that the substance does that creates these problems? One of the things we find is that there's a diminishment of judgment when we use substances. So we do things that we wouldn't normally do. We say things that we wouldn't normally say. So if it relates to a family, I may say to my child after I've had 5 or 6 or 7 beers, something I would never say to them or to my spouse, things that I would do. Prisons are full of people that have done things under the influence of substances they would never have done. So the substance diminishes our ability to, our filter, that part of us that says, that's not who I am. That's not what I want to do. So it diminishes judgment, our ability to discern what's right, what's wrong, those kinds of things, as they relate to drinking and driving, the legalities, those kinds of things. So we may be taking a perfectly legal substance that's been prescribed to us by a physician, as in the case of most opiates, and yet it can be illegal if we get behind the wheel of a car and we're intoxicated and we hurt somebody. We're still liable for those damages to people. And obviously with health, you know, the substances very often, alcohol especially, methamphetamine, those kinds of substances create health problems, whether it be esophagus problems, stomach problems, liver problems with alcohol. Opiates create a withdrawal syndrome that is, and we'll talk about that later a little bit. School and work for adolescents and adults. If we come up positive on a drug test, that's a negative thing. It may be that we're just using marijuana and we think that's a soft drug. It's an herb. God grows it. It's not really a drug. But our work may not agree with us on that premise. And so what ends up happening is we have work-related problems, and we are written up or we're reprimanded in some fashion, and there's some negative consequence related to that. So that's one of the things that we see is a diminishment of judgment. The other thing, and I mentioned this briefly, is that we see an increase in tolerance. And that's not an acceptance of other people's behavior or something like that. It's the brain's capacity to and tendency to accommodate and adapt to anything we do to the brain. And that's true for the whole system, your entire body. But the brain is very, very susceptible with its receptor sites and neurotransmitter systems and whatnot. It's a very delicate instrument. And when you're putting in a substance that is changing feelings, you are changing brain chemistry. And so the brain, by necessity, will adapt. It will accommodate. And the way the brain adapts to many substances, like tranquilizers, which are Xanax, Valium, Librium, we mentioned those. And also, as we're going to talk about more today, opiates, alcohol. The brain develops a tolerance, and so pretty soon it's taking more to get to the same level. And so in order to stay out of a state of withdrawal, we have to have a certain level of that substance in our system, or we start to go into a state of withdrawal, which can become incredibly difficult. And we're going to go in specifically to how opiates affect the brain and why it's so difficult to get clean and sober off of that. And then we look at also the physiological effects. So especially with drugs like alcohol, methamphetamine, alcohol permeates every cell in your body. And with enough consumption of alcohol, there's a virtual guarantee that some system will be adversely affected, whether it's the esophagus, because you have a poison going down, constantly down into the stomach, and then depleting the mucous membranes and the protective mechanisms of the stomach lining, and creating ulceration and lesions and sores in that fashion, or whether it's creating liver problems, that eventually there's cirrhosis of the liver, or pancreatitis, the things that are associated with alcohol. So we see physiological effects. So these are the kinds of problems that we're seeing with specifically with substances of abuse. One of the key considerations in any psychoactive substance, especially those that we become dependent on, is it gives us a very predictable high. It's going to take us from point A to point B, and we expect, based on our experience, that that is going to happen. If it doesn't happen, then somebody cheated us. If we bought it off the streets, then somebody gave us some bad stuff and didn't give us the real deal. If we got it from a pharmacy, then obviously they gave us the wrong medication because it didn't work to achieve that. Now, tolerance can be a factor in that, but ultimately, the expectation is that the substance is going to give us a high. And we become dependent on that high. We want that high. Now, for some people, based on genetics, one substance will give one person a high, and another person, they won't get it. I've had people that I was drinking with say, "Oh, no more for me, I'm beginning to feel it." And I'm thinking, that's the point. That's why we're here, is to feel it. And so I wouldn't want to drink with those people because they don't understand that everything we've done preliminary to this is to get to this point where we're high. And a lot of people don't experience that. In fact, the vast majority of the population simply drinks to be social, have a couple of drinks, and that's it. I drank because I wanted to get from here to here, and this was high. Different substances did it in different ways, but the goal was always the same, to get high. So when we talk about getting high, one of the problems also is that we're willing to do almost anything to get that high. Once the brain and the mind have become attuned to the fact that I don't have to live over here in this boredom, this loneliness, this sense of inadequacy, this sense that I can't dance. I used to hate to dance. I would get up there and it would be the longest 2 minutes in the world. But I do it because that's what you had to do if you wanted to have a relationship with that girl. So you went out and you danced, but I hated it. I felt like people were sitting around going, Jesus, that guy got some kind of neurological problem, you know? And but if I took 5 or 6 drinks, all of a sudden, I was the greatest dancer in the world. So it had changed. Nothing had changed. I wasn't any better dancer, I assure you. But I had a different sense of how I danced. I had a different sense of myself. Now I'm envisioning that people are saying, whoa, look at that guy. Can he dance? Wow. Now the only thing that's changed is I've had sufficient quantity of ethyl alcohol to be able to change the way I feel and achieve that high. And so we begin to chase that high constantly. I used to use cocaine, and I would inject cocaine. And I would inject, and then I'd go, oh my God, too much. This is it, I'm going to die. And my heart would be pounding, would feel like my hair was standing up. I had lots of hair then. And I could hear the refrigerator, it was just pounding, and I thought, oh no, I've done too much, I'm going to die, it's all over. And I'd pray to God, please don't let me die, I won't do it again, but, you know, just get me through this one. And given enough time, I would come back and my heart rate would come back to normalcy, and next thing I know, I'm fixing it up again and doing another. And then there I am again, I'm back in that state of, oh my God, I've done too much, I'm going to die, please don't let me die. That's kind of crazy. But what we end up doing is chasing that high, trying to get back to that place where we felt so good, where we felt like we were normal. And that doesn't happen for everybody. Some people, when they drink, they feel dizzy and out of control. Some people do cocaine and they go, my God, why would you do that? It makes you feel paranoid. And, you know, you're looking out the window all the time because you think the police are out there. Why would you even consider doing that? And yet, for those people who are prone to addiction, it makes absolute perfect sense. Because for us, that high is is so necessary to, at some point, even to our existence on a very primal level. So the last piece of this is, as we go through all this, we began to have all these legal problems. The legality of the substance. I mean, just most substances are illegal because they're psychoactive and because their use causes these problems. So whereas pharmaceutical medications may be prescribed, we can get addicted without ever having legal problems because it's been prescribed to us, we can still end up with tolerance and judgment diminishment and physiological effects and the problems there. We're just not going to get arrested for being in possession of it. But it's still one of the common elements of negative effects of using drugs. So when we look at, okay, what's wrong with drugs? Because I especially hear from 16-year-olds, well, they should just be legal. Just make all drugs legal. The problem is that society has found through the years, because opium used to be legal. You could get laudanum easy way back in the 1800s. No problem getting opium. There were opium dens. Cocaine was in Coca-Cola. So cocaine was easily accessible, and then Bureau of Narcotics and Dangerous Drugs came in and said, no more of this, we're discontinuing this, because there were negative effects. So therein lies the problem of, and why society has said, this is not okay, and created a legal system that ensures that if you use substances long enough, especially illegal substances, at some point in time, especially because there's diminished judgment, we're going to have a problem. Okay? So let's look specifically now at what opiates do. And opiates, we need to talk about all the way down to codeine, Vicodin. That's the one that, you know, people, you go in to get your teeth worked on, you have a surgery, you're prescribed Vicodin. Double strength Vicodin is Norco. Probably quadruple strength Norco, although it's a separate substance. We go from hydrocodone to what's called oxycodone. And it's OxyContin has become a very, very readily abused substance all over the country. And people get addicted to it. And yet, for some people, they need to be able to have relief from pain. They need oxycodone because they've had their hip replacement. I've got a friend right now whose hip was redone a few days ago. He needs to have that painkiller. But in his case, my assumption is that he will go through a few days of using that, and then he'll start his physical therapy. The pain will have diminished, and he won't have the same kind of response that I would have, or that 20% of the population would have, that we would suddenly find that it did something magical for us. It didn't just kill the pain of the hip, but it also killed that emotional pain that was stuck down there for so long. There's a real interesting thing that happens with opiates. And it doesn't matter whether it's narcotics like heroin, morphine, or synthetic narcotics like Dilaudid, Demerol, OxyContin, all those kinds of things. They all work on the same area of the brain. We'll talk about that. But we can almost predict from the day that the person takes the substance whether they're going to have a tough time coming off or not. If that person, when they inject the substance, simply has relief from pain and goes to sleep, they're very, very likely to have absolutely no problem coming off the medication. They're not likely to abuse it. They'll use it up to the point that it's necessary. They'll discontinue it. And when they discontinue it, regardless of the length of time that they used it, they won't have a problem typically stopping the use. 20% of the population or so, some percentage of the population, a minor percent of the population, has an atypical response. And that atypical response, from the very first time they use it, instead of it just killing pain, which it does, it also stimulates their central nervous system. Instead of sedating and putting them to sleep, they get a almost speed-like effect. They can't sleep. They want to talk. They want to get out and do things and, clean the house and work in the yard and talk to their friends, and it disinhibits them. So it has a completely different effect than that other person that took the medication. And from that perspective, we see that the medication, some brains are just sitting there ready for addiction, and others, you can't turn them into it. I remember my Aunt Bernice, we called her Old Lemon Lips because she always complained about everything. She was just always looking around, and nothing was ever good enough. And I used to take her Dilaudid, and I would crunch it up, little bitty pill, wondered how they got all those good feelings in that little bitty pill, and I would inject it. And she could get it any time she wanted. Never used it, seemed to me. And 2 or 3 years later, I end up in treatment. And afterwards, I go back to Oklahoma, and I go to Aunt Bernice's. She's in a nursing home, and we're talking about things, and we talk about my recovery and stuff like that. And she says, Rocky, I wish that I could be an alcoholic or a drug addict. I wish that I got the same effect that you get from those little white pills that you used to steal from me. And but the thing is that when Aunt Bernice drinks too much, or she used Dilaudid, she would feel dizzy and out of control. She didn't like the sensation. So we're in the same family tree. She's even on my dad's side of the family where all the addiction is. That's the Irish side. And she's on that side of the family tree, but she just doesn't have the capacity. She can't be an alcoholic. So when we talk about the genetic component of alcohol or drug addiction, as it relates to opiate addiction, she's a perfect example of somebody who can't be a drug addict. It won't work for her. It just doesn't do the deal. Now, for me, it gave me a sense of freedom, of energy, of excitement, of enthusiasm, of safety, there was just a warmth that came over me when I injected or used any opiates. So let's look a little bit at what happens to opiate people who use opiates and break opiates down a little bit. One of the ones that we always hear about is heroin. And heroin now is we're seeing significantly more heroin because it's readily available. They're growing it in Afghanistan and pumping it into the country. South America has been planting more and more heroin. So we're seeing more and more opiates coming in the form of Mexican brown heroin and then heroin from Afghanistan that has an incredible purity, very high level of purity. But heroin is a narcotic. And there are other forms of heroin that are very similar. Then you have things like Demerol, Dilaudid, that are very, very powerful synthetic opiates that are typically used in surgical procedures, in medical procedures, for people who have terminal diseases where the physician is not too concerned about them becoming addicted because they know that they don't predict that they're going to be on the planet too long. And so they're not too worried about them. Or they have a significant enough pain level that it requires that power of a medication, of an analgesic effect to be able to diminish the pain for that individual. Then we drop down into OxyContin. And the generic name of that is oxycodone. And we've seen that just a huge uptick in oxycodone. Then down to Norco. And we're still all in synthetic narcotics. And then Vicodin. And then finally, you don't see too much abuse of this, but codeine. Those are synthetic narcotics. They do the same thing. They work in the same area of the brain. They're just produced in a lab. They're not grown out in a poppy field somewhere and somebody's developed them from nature. We've recreated the same effect in the brain with that medication in a synthetic capacity. Now we have to ask ourselves, well, what is it that opiates do? So when we look at the brain, there are things called receptor sites in the brain. And they're something like this. They kind of look like jellyfish, if you will. And they have these little tentacles. And all of us have them. And they're basically there. They're there for all types of different brain functions and situations that might occur in the course of our life as protective mechanisms. And this specific one, the mu and kappa receptor sites, are specifically designed to pick up a chemical in the brain called endorphins. And so if you're 8 years old and you've never done any kind of opiates, you've never been addicted to anything, and you break your leg or you start to cry, then what happens is your brain, your system releases, your brain releases endorphins. Endorphins are simply indigenous morphine. Indigenous means it's already in our system, and it's morphine. And so that receptor site has been created to be able to accept endorphins. So the endorphins come into the system, into the bloodstream, they attach to these tentacles, they go down the nerve pathway, and we get the effect of some element of pain relief and discomfort relief. It's not a lot, but it's nature's way of dealing with pain. You'll hear people sometimes say when they've been in accidents of one form or another. I had a lady who used to ride horses with us, and her leg hit a metal pin and broke at the thigh and flipped all the way over, and her leg was on the other side of the saddle. She didn't experience any pain. Part of that was shock, part of that was she had a huge amount of endorphins that were stimulated into her system and picked up by the mu and kappa receptor sites. Well, science has learned that we can use these medications and drugs to be able to amplify and regulate pain through utilization of this mu and kappa receptor site system. And so when we take OxyContin, Norco, Vicodin, the same thing happens. It attaches to the tentacle, goes down the nerve pathway, and there is a sense of relief. And as we do more, we can get a higher and higher and higher sense of relief, to the point that we can get that, what we talked about here, that high that we start to chase, that euphoria. So it may start out that we have a leg injury, a knee surgery, a shoulder surgery, an automobile accident, a sports accident. And we start out, we don't know, the doctor gives us the medication, and we go, wow, that sure does feel good. And maybe 5 or 6 or 7 times, there's no problem. We take it, come off it, not a problem. And then the 8th or the 9th or the 10th time, we end up taking it maybe a little bit longer, or the brain reacts in some different way. But the next thing we know is we're having a hard time coming off. And so when we stop the medication, we go into a state of withdrawal. Now, one of the things that happens with these receptor sites, and this is something relatively new. As I said, for years, we didn't understand why we couldn't get opiate addicts clean and sober. You know, with alcoholics and methamphetamine and cocaine and other drugs of abuse, we could run a 60-70% recovery rate because we looked at outcomes and followed that. And yet, with people that had addictions to opiates, it just seemed we could get them through that initial withdrawal phase where the cold sweats, the cold turkey they call it, and they're sweating but they're freezing and all that kind of stuff. It's just an awful state. We could get them through that initial state that we thought was the withdrawal syndrome, and that was it. They're done. Okay, now let's get on with recovery. And what we found was that they just kept whining about not feeling good, not feeling the same, not feeling normal. And we're talking not weeks, but months later, they're still in this. And what we found was that most of them at some point in time would return to the use of the substance again. And I think, our tendency was, since we didn't understand, our tendency was to simply, opiate addicts are just like that. And I know of treatment programs that refuse to take them into their program because it skewed their outcome studies. And so they said, no, go to a methadone clinic. And methadone, let's discuss that real quickly, is another narcotic, and it falls in here in the synthetic narcotics. And all methadone is a very long-acting synthetic narcotic. So it affects this receptor site for a long, long time. It stays in the system and it affects this mu kappa receptor site for an extended period of time. Whereas the Vicodin has a 6-hour half-life, the methadone, I believe, has somewhere in the neighborhood of a 24 to 48-hour half-life. So it stays in the system for a long, long, long time. I worked in a methadone clinic right out of my own treatment. I never saw one person that achieved sobriety that was able to get off the methadone and stay off the methadone. I'm sure there are lots of people that have that history, but I never saw anybody in the year and a half that I worked at that methadone clinic. What I saw were people coming in the morning, getting their dose of methadone every morning, and their methadone dose would go up because of tolerance. And so they would start at 30 milligrams, then it would be 40, 50, 60. Next thing you know, they're at 120 milligrams, and the staff saying, well, you can't be any higher than that. So they'd start them on a 21-day detox, and they would bring them down. But in that period of time, they'd start using heroin or other opiates because they couldn't take the withdrawal. They couldn't stand that. Get them down, then they'd start back on the methadone again. Then they'd come back in and get their legal opiate. And if that's all we had, maybe that would be better. But with the advent now of Suboxone, we have a completely new ballgame in terms of the treatment of opiate addiction. Because, and now we can talk a little bit about what Suboxone does. And you may hear Suboxone referred to as Subutex. And Subutex is simply one of the ingredients alone without the other. So Subutex is simply buprenorphine, which is an opiate that's been around forever. Now, buprenorphine, while these are synthetic narcotics, buprenorphine is a semi-synthetic narcotic, which means that it is a partial agonist to the receptor site. These are full agonists. They fully activate that receptor site. Suboxone is a combination of buprenorphine and naloxone. Another medication that's been around for a long, long time. If somebody goes into the emergency room and they're overdosing on opiates and they're about to die, then they shoot them full of what drug called Narcan. That's naloxone. We've discovered in recent years that alcoholics have diminished cravings by taking a drug called naltrexone, just another name for naloxone. It is an opiate blocker. So what it is an antagonist, an opiate antagonist. So it blocks the receptor site. It basically closes it down. So naloxone has that effect of closing the receptor site down. Buprenorphine is very unique in its effect on that receptor site, because what it does is it has the capacity to come in and to gum up that receptor site. Now, if the individual is on OxyContin and they're taking OxyContin or heroin or any other of these drugs, buprenorphine has a greater affinity for that receptor site than the other opiate. So what will happen is it will displace it off the receptor site, and the person will go into a state of withdrawal for a period of time. For about 14 hours, they're going to be in withdrawal, and a real gnarly withdrawal. That's why when Suboxone is induced into someone in a clinical setting, they have to be in withdrawal, because we don't want to throw them into an uncontrolled withdrawal. We want to be able to have them take the Suboxone. It's sublingual, it goes under the tongue, and it's absorbed through the mouth rather than gastrically. I believe the gastric absorption rate is somewhere in the neighborhood of 2% versus 80-90% through the salivary system. So with the buprenorphine alone, not even counting the naloxone, but just the buprenorphine by itself, it displaces all of these opiates. So the magical thing for Suboxone is you can't use opiates if you're on Suboxone. It is an opiate blocker by itself if you're taking buprenorphine. What the federal government has done, NIDA and DEA, they've added naloxone as a double lock system and as a way for people not to be able to get high on buprenorphine by injecting it, even though you really can't. Because the bottom line for the use of buprenorphine is it closes the receptor site down. So if this is the receptor site and it's agitated, what the buprenorphine does is just close it. So it becomes non-functional. So the person's no longer in a state of agitation and withdrawal. The withdrawal from opiate addiction we need to talk a little bit about, because most people don't understand that opiate withdrawal is different from any other type of withdrawal from what we can tell. Because of the area of the brain that the mu and kappa receptor sites, where it is, it's at a very basic primal area of the brain. And so the sense that a person will have, and we hear this over and over again from people who come into treatment with us, that say, I feel like I'm going to die. I know the books say I'm not. I know the doctor said I'm not going to die because of the withdrawal, but I still feel like I'm dying. And I think it's probably analogous to someone who's anorexic. They can look in the mirror and they can say, my God, I'm 5'8" and I weigh 70 pounds. That's not normal. I look skinny. I know that. I can understand that cognitively, but I still feel fat. And for the person who is coming off of opiates, the feeling they have is they are dying. And so for them, the alternative is on an emotional level, which is what drives most of our behaviors. I'm either going to use again or I'm going to die. Now that doesn't even take into consideration how it feels to go through withdrawal from opiates. Because the sense is you don't want to eat. You may have diarrhea and vomiting. You have cramps. You can't get warm, and yet you're sweating profusely. And this may go on for an extended period of time. Usually what we see is 14 to 25 days of acute withdrawal where they're very sick, and they certainly can't function in a group therapy setting because all they can do is just kind of hang their head. They feel depressed. They have absolutely no energy to do anything, to even think. If you ask them questions, it's like there's nothing there for them to really pull on to even, it takes all the energy that they can muster to answer a simple question like, what's your birth date? When they're in full withdrawals. It's an awful experience to go through. But if it was a finite period that we knew, okay, it's going to be this amount of days and then it's going to be over, then we'd say you just got to get through it. And maybe we could, and we've used in the past drugs like clonidine, which is a high blood pressure medication, and drugs like benzodiazepines like Valium to try to offset some of the symptoms. But we knew that it was still going to be a pretty rough ride, a real rough ride. The real problem with opiate addiction is that as science has looked at what is it that happens in the brain of a person that's opiate addicted, is that there's a transformation. And pretty soon, these receptor sites have changed. And some scientists hold that the brain has adapted and accommodated the excess opiate in the system, because you see, when you're putting all this into your system, the endorphin system can never catch up with that. It could never produce that quantity. So the brain has to have some way to accommodate it and adapt. The brain is always trying, the human body is always trying to accommodate through what's called homeostasis, coming back to a state of equilibrium, of balance. And so the brain does that by saying, okie doke, if there's going to be so much coming in here, then the only thing I can do is create more receptor sites. We're going to change the structure of the brain in order to accommodate these endorphins. The opiates. And then what happens is the endorphin system shuts down because we're putting in more. It's been a year now that I've been on these opiates, or 6 months maybe. And so my receptor sites have changed. Now I go to come off, I can't come off. And I can't tell anybody because I'm ashamed. And so every time it comes around to a holiday and I'm not at work because I know I can't come off the opiate and still function at work. So when it's holidays, I tell everybody that I'm sick and I just curl up on the sofa and try to get through in that period of time that I'm not going to have to go to work and get through my withdrawals. No way. There's not enough time. And the other thing that happens with opiate withdrawal is it's a two-phase thing. There's the acute withdrawal that may last 10, 14, 25 days, 30 days. I had a Major League Baseball player in our office. And 30 days from the time he'd used opiates. And he had simply gone in for surgery and been put on opiates, didn't take them any more than prescribed by his physician, and needed to get off, couldn't get off. He'd lost weight, couldn't eat. The morning that he was brought in, his parents had spoon-fed him oatmeal to try to get something into his system. They told me of what had happened. He couldn't even give me the history. He didn't have enough energy. He just sat there with his head down. His sense was one of shame, fear, not knowing what to do. Where's my career going to go? I'm supposed to be working out. I'm supposed to be in shape. I've got to be in Florida for spring camp. What's going to happen? And we were able to start him that day by 2:30 in the afternoon on Suboxone. I got a call from him at 3:30. He was on his way to the gym to work out for the first time. He was able to get into shape before spring ball, went down, went through the whole spring camp, ended up MVP. And simply took a very small chip off of a Suboxone tablet each day that he put under his tongue, prescribed by his physician, absolutely legal, and he felt normal. And that's the thing we hear over and over again from people. When they start on the Suboxone, it's universal. I feel normal again. I had a lady in my office, 18 months since she had used opiates. And was Susie housewife. She didn't have a job. Her job was taking care of the kids. But she was in PTA. She was in, the kids' little league. She was involved in everything. She was a go-getter, high-charging energy gal. And she had a surgery. Took opiates for about 9 months, prescribed by her doctor, just according to what her doctor told her to take. Couldn't come off. She had one of those brains that reacted to the opiate in such a way that she got a sense of stimulation when she took it. She said, yeah, I couldn't understand. I felt like cleaning the house. I was more productive. I was more active. And I felt good. It was great. Didn't hurt. Didn't think there was anything wrong until she tried to come off. And she did everything. She went to a psychiatrist. They prescribed her every antidepressant that I could come up with. She had taken. To no effect, to no avail, to no benefit. And so what ended up happening was that she ended up taking the Suboxone. She told us that, look, at this point I would kill myself. This is 18 months into it. I would kill myself if it weren't for my kids. We started her on Suboxone, and immediately, first thing out of her mouth, I feel normal. For the first time. So let's talk a little bit about some of the benefits and downsides and whatnot. Suboxone can be used to stabilize people so that they can function. They can get into group. In our clinic, what we tend to do is, with the physician's obviously prescription and assistance, they prescribe the Suboxone. We induce it. They induce it. The person has that sense of, all of a sudden, I feel normal. Everything's okay. There's a tendency, and that's one of the dangers, for people to think, well, now that I've taken this, I'm okay. Everything's fine. I don't need to do anything else. We spend a great deal of time explaining that there's still addiction here, and that the opiate was working on some source of pain, or they wouldn't have had the experience they had. And that they're going to still have to look at that, but now they have the capacity to do that because they feel normal, and they can begin to have access to those feelings. And so we get them into going to group therapy, individual therapy, 12-step meetings, things like that. And usually stabilize them for 4 to 6 months, depends on individuals, depends on their history, how long they've been using opiates, all kinds of different variables and factors. And then we'll start to titrate the dose very, very slowly and bring them off. Usually what will happen is the person will, by their own, just start taking less. So if initially when they came in, they started out on a dose of 16 milligrams, pretty soon they're down to 8, and then the next thing we know, they're down to 4. You don't see that with these drugs. You don't see people coming back to their doctor saying, I don't need that much, I'm taking less, very often, certainly not addicts. But with Suboxone, you see people coming in and saying, I don't need that much, because they find out that 4 milligrams closes up that receptor site and takes them out of the withdrawal, and they feel normal just as well as the 16 did. So we start bringing them down, and it's 4, and then 2, and then 1, and usually everything goes fine until they get down to 0. And unfortunately, the next step is usually a return of the withdrawal syndrome. And those receptor sites wake back up again, and they go into a state of dysphoria, and they go back into what I believe to be a lesser withdrawal. What we encourage our patients to do is to remember that they're in recovery now. And we spent that 6 months or whatever period of time it is, hopefully indoctrinating them in the ideas and concepts of recovery. of talking your feelings out, of working with us, not deciding to go off on your own. And so what we are able to do is give them a sense that we're working together. We're not going to let them get into that awful pain again. And so we use the Suboxone to be able to do that. And so what they need to know is no matter what, you don't go back to the dealer. You don't go back to that doctor that was giving you the opiates before. Stay here with us. We'll get through this. We'll work through this. Some people end up going back on the Suboxone. Some people end up staying on the Suboxone, given their history. And there's tremendous controversy in our field as to whether that's recovery. My belief is that our job is to bring people to a state of normalcy, of functionality. Okay, we've talked about what addiction is, how opiates play into that addictive process, and some of the dilemmas it creates for individuals and families and whatnot. And I think we need to look now at this new drug, Suboxone, and its ability to medicate and its ability to enhance what we do therapeutically with people who have opiate addictions. So, and we need to take a view that is difficult for us, those of us in the addictions field. You know, I think most of us have been through some form of treatment, and usually that was very much focused on abstinence from all psychoactive substances, no matter what. And that was challenged 10 years ago or so when antidepressants came along. And the field had to absorb that. And it was difficult in the beginning because there were many in the field who felt that use of antidepressants to treat any kind of anything, any drug was not okay. And antidepressants were liable to be just as addictive and just as problematic as, say, Quaaludes had been, or Valium had promised to be the answer prior to that. And wasn't. And so I think we reacted to that. But eventually, the field and those of us in the field accepted that antidepressants, in fact, enhanced our ability to treat the whole person, and that we weren't just treating addiction. We were treating a person, and our goal was to be able to increase their ability to function in life and their ability to experience joy and happiness and participate with their families, and that antidepressants did that. And I think we've come to another juncture. And this only relates, obviously, to opiate addiction. But it's a very, very important element. And as we've determined, opiate addiction is growing exponentially across the country, I think across the world. And so this is an important element as we look at this, because there are going to be some people who are going to say, well, you're just trading one drug for another. And while I believe that would be true during the times that with methadone, we just traded one drug for another. Methadone was just another long-acting opiate. We were never in favor of using methadone. And yet I have to say that there were a lot of methadone clinics that probably saved people's lives. And in the concept of harm reduction, were very, very effective. My own bias was that abstinence and recovery was complete elimination of alcohol and drugs that are psychoactive. Antidepressants didn't fall into that, so we could bring that into the fold. Now we have Suboxone, and I can tell you that there are a lot of people in this field. I had a physician friend of mine who's ASAM certified and has been in this field forever. And he said the most difficult thing he has is getting counselors to accept people on Suboxone. They won't let them into their groups. They won't work with them. They say that they're not clean and sober, that this is a narcotic and therefore they are simply on narcotics still and nothing's changed, and that they're not really in recovery. And I think we need to rethink that and take a step back and remove our own biases for a period of time and review this substance in the clear light of facts, and not rely on our own biases and our own experiences of how we got clean and sober and things. When we looked at those things that made drugs bad, those things that made drugs harmful, alcohol inclusive as a drug. They were the things that created chaos in people's lives. And so we talked about judgment, tolerance, physiological effects, the high that we chase, and the fact that it's illegal. So let's take a look at Suboxone versus opiates and look at the realities. And I want to share one more experience. I was speaking with a professional that I respect from a very highly respected treatment program in the country, and we were debating the relative merits of Suboxone. They initially had refused to use it at all, and then after about 3 years that we'd been using it, they finally came along and said, okay, we'll use it, but only for detox and a very rapid detox. And he and I debated the possibility that, what about the person that needed to stay on it for an extended period of time? And you know, what are your recovery rates looking like when you do rapid detox? And he said, well, we've got about 30% of the people that stay clean and sober, which means about 70% relapsed and went back to opiate addiction, which we all know ends up in either incarceration or death. And broken families and all the insanity that comes with opiate addiction. So it wasn't a little figure, and it certainly wasn't a success in my mind. And I asked him a question. I said, what is the problem with someone staying on Suboxone? Because it doesn't give them a high. They can't use opiates while they're on it, all those kinds of things. And we went through all the relative benefits and liabilities. And he said the number one liability, and the only one he could really point to, was that it made them incapable of accessing their spirituality. Now, I had a tough time with that because my first instinct was to say, well, how did you measure that? Because I don't know how to measure that. I don't know how to measure someone else's spirituality. But I think that whatever our reason is for saying this substance is somehow not to be used for any length of time needs to be rethought. And it doesn't mean that everybody needs to stay on Suboxone that's opiate addicted, but I think that we have people that ultimately will get a better result from that. I was asked to do a presentation for CADAC, and we've been using Suboxone now for about 5 years. And we've got some patients that have come off, and we've got some patients that have stayed on. So we called every single one, and we contacted about 80 people. And they were evenly split between the people who stayed on and the people who had come off. And we asked the people who had come off, have you relapsed to opiates? 100% of them said they had. They had relapsed to opiates. They had gone back to using OxyContin, Vicodin, something. We asked them, why'd you come off? What were the factors that went into that? And number one factor was that somebody in their life told them that they themselves felt they had just swapped one drug for another. And so they felt an element of pressure from a spouse, family member, to get off the Suboxone. The other reason we found was that there was a high cost to the medication. So they quit taking that for that reason. I hardly believe that accessing OxyContin or Vicodin or Norco or heroin is going to be cheaper, even in the short run, than Suboxone. But nevertheless, that was the reason they gave. The third reason was they wanted to be able to get high again. They wanted to be able to go use opiates again and get that nice warm feeling, and they couldn't do that. And so that was the reason. In all the cases, they couldn't report that their life was better. Life in the areas of functionality that we asked had been diminished, especially as it relates to family. When we looked at the group that had stayed on Suboxone and were taking very small doses, and we found that the dose had gone down to 8 milligrams at most. Most were in the 4 to 2 milligrams. In each case, they reported no relapse, increased functionality in terms of employment, in terms of their relationships in their family, in terms of their feelings of contentment, those kinds of things. Because what we have to remember is that the opiate addiction isn't just that gnarly withdrawal in the beginning. there's a post-acute withdrawal syndrome that goes with it. And that's what gets people. It's that period of time that we go through, we get through that tough time where we're sweating and all that stuff. And then we get to where it's supposed to be normal. We're supposed to feel normal. We don't feel normal. The receptor sites have not adjusted. And who knows how long it takes for that to happen. Obviously, it's going to be different in different individuals, given different experiences and brain chemistry and whatever else. But there's that feeling of what we call anhedonia. And it's very close to depression, but it's not quite depression. It's that feeling of inability to experience pleasure. You can't look at your kids and just feel that joy. You can't feel the sun on your face and go, oh, I like that. You lose the excitement and the enthusiasm when you're in that state of mind that is anhedonia. And I think that is the prolonged state that unfortunately is part and parcel of opiate addiction. It's an acute phase of withdrawal and then a protracted up to years of anhedonia. How many people can stand that before they eventually go back to using opiates again? And where in this do we need to look at harm reduction? So let's look at the realities of Suboxone. In terms of one of the things that we already talked about, which was diminished judgment or functionality. Does Suboxone diminish functionality or judgment? No. The person has, the only effect it has is it closes up the receptor site. So it just doesn't work. So there's no high that comes with it. There's no diminishment in judgment. You're not finding somebody that's on Suboxone that's saying something to a loved one that they wouldn't. You're not finding somebody that's on Suboxone that's having to spend inordinate amounts of money, things like that, to get their drug. So no. Does it with Vicodin and OxyContin and other opiates? Yes. It diminishes judgment. Is there a risk of overdose? No. You can't overdose on Suboxone alone. It shuts down the receptor site, so there's no overdose potential. So the answer to that, is there a risk of overdose with Suboxone? No. Now, if you mix it with other medications, there can be. And we know that mixing with benzodiazepines like Xanax, Valium, Librium can, in fact, be, there's potential for death with that or overdose. With other opiates, yes, obviously. It's a huge problem. Does it create a high? No. I haven't had one person that has come to me and said, boy, that really felt good. And I think one of the tests is that you don't see Suboxone out there for sale as a drug to get high on. You do see it for sale because it's so expensive to go to a doctor to get it. So you see it on the streets for sale, but only to mitigate withdrawal, which is exactly what it's for. Not because people are getting it because they're calling up and telling their friends, boy, I've got some really good Suboxone, you need to come down and get some. It's just what it is. It's an opiate eliminator. It's an opiate blocker. Is it illegal? No. If it's prescribed by a physician, it's not illegal. So Suboxone isn't illegal. Are opiates? Obviously. So there's always the chance, not the chance, the probability that sooner or later you're going to have it in your pocket or somewhere, somehow, some way, it's going to turn up positive, and you're going to have a negative experience with the police. It's illegal to have those drugs. We have people coming in all the time that have written prescriptions themselves, especially nurses. People who have bought it on the internet, gotten caught, gone to Mexico and had terrible experiences down there, trying to get enough opiate to stave off the withdrawal. Does it create a tolerance? No. Suboxone actually diminishes tolerance. We see people go down in their use of Suboxone on their own. Do the opiates? Obviously, yes. Does it create health problems? No. The only thing that I know of is could create some constipation. That's true for both opiates and Suboxone. Suboxone is an opiate, as we determined. Buprenorphine is a semi-synthetic narcotic. So it has that capacity. But there are no real health problems with that. Now, with opiates comes very often the health problem of injecting and the problems when you circumvent your normal natural system of protection. And very often people who use opiates move from smoking it into injecting it because they can get more bang for their buck. And it gives them that high because that's what they're chasing. They still want to get that high. Increased costs and thus financial problems. With Suboxone, if it's covered by insurance, then it's the same as any other medication that you have. You pay your physician, you pay for it, that's it. If you're out on the streets getting OxyContin or Vicodin or anything else or heroin, then you're basing your ability to stay out of withdrawal on whatever the DEA is doing or the local police are doing in terms of arresting people and thus creating a lesser supply. And when supply goes down, when supply goes down, then costs go up. And so it costs more money. But it doesn't cost more money if you stay on the Suboxone. Is there a withdrawal? Yes. There's a withdrawal for Suboxone. The belief is that coming off of the Suboxone, because it is a partial agonist, it's a semi-synthetic narcotic, the withdrawal is diminished. It's not as grave or as great or as long-lasting as the withdrawal from a full agonist. But the fact is that there is a withdrawal. That's true. But it's a withdrawal that was already in place when the Suboxone was initiated. So that was going to happen no matter what. What the Suboxone was able to do is to eliminate that for some period of time. And so when we look at these things and we look at the pluses and the minuses, I think there's one thing we need to mention, and that is if somebody is in an automobile accident or they're facing surgery, then they have to have some awareness of how are they going to deal with an acute pain situation. And the reality is that if the treating physician is aware of opiate blockers, they have the capacity to come over the top or use other medications for pain relief, those kinds of things. If there's a surgery planned, then simply the Suboxone is eliminated, and within about 2 days you can reintegrate the opiate, and then the surgery goes on. And then if there's a period of convalescence where there's going to be acute pain that the Suboxone cannot, that the buprenorphine is incapable of diminishing that pain situation, then they can take what they need to take until the time's ended. And then they get back into, we reintroduce the Suboxone, and that's their shield against relapse, a physiological shield against relapse. So am I saying that this is the answer? I'm not. What I'm saying is that as a field, we need to rethink some of our biases. And as individuals and families, I want you to think, what was it like for your loved one when they were struggling with opiate addiction? What did they deal with? What were you dealing with? What were the fears that you had? And how has it been since they've started on Suboxone, or someone you know, or as you consider these facts? When you look at the relative merits of each, I don't think there's any doubt that Suboxone has a place in the treatment of opiate addiction. And whether we decide that the best way to treat it is through a gradual titration, or as some physicians, ASAM certified physicians believe, the very best way is for an opiate addict to assure themselves that they're not going to relapse, is to maintain that shield of Suboxone and also work a program of recovery, just like every other addict. And that gives them the very best chance of saving their lives. And each of you that has either gone through this yourself and is watching this because of that, or it's because a family member has gone through it or is going through it, you have to look at these factors in this and eliminate bias and look at the truth of the matter. And my experience is, after 5 years of using this, is that this truly, in the 28 years that I've been in this field of treating addiction, this is the biggest change I've seen in our field. And I think that we now have a new tool. And I think that the future is going to allow many more changes. And our field needs to be open to the understanding that science is going to bring us to treat people better, maybe differently, but we ultimately come out with the product of people's lives being saved and the quality of their lives enhanced. And that truly is our job. Thank you.